And thanks to everybody for their statement this morning. Just my first question is in relation to use a medical term, I think all the vital signs are progressing generally in the right direction around Slontacare and its concept. I think the vast majority of people in this country would want to see kind of the concept being implemented as soon as possible, because there's obviously historical kind of inequalities in relation to access to healthcare. And I know the new CEO last week, Mr. Gloucester, was a breath of fresh air to a certain degree in relation to what he wants about his 5-year tenure in relation to being hands-on and so forth. But those that are listening this morning will want to know a number of things. What is Slontacare going to do to address the inequalities, and there are historical inequalities in relation to bed capacity, in relation to waiting times and so forth. So obviously the waiting list action plan is a good concept again, but in reality, I mean, I know the ICAHA have been very critical of the plan because their kind of main critique is that this issue will take over a decade to get on top of in relation to the waiting time because of the historical inequalities around bed capacity. So what in the concept of Slontacare is that, particularly in bed capacity, because if it can't address bed capacity, there will be a knock-on effect to all the things that we're trying to do. So what are we doing in relation to bed capacity?
Thanks. Thank you, Deputy. We don't accept the IHA's analysis. That's going to take 10 years to address the waiting list. That's not acceptable. We don't accept that.
Why not?
Because I don't think it's based on an analysis that's properly specified or set out. Right. We are making progress in relation to waiting lists. We are reducing the number of people who are long waiting and the number of people who are waiting in excess of the Slontacare targets. We are making progress. We made significant progress last year, and we're hopeful for this year, Deputy, that will make more progress. There is a challenge that every year, like the number of people who are treated, like the number of outpatient consultations on the wait, I think that's 3.5 million. The number of day case procedures is around 1 million. I think the number of inpatient procedures, I think it's 300,000, 400,000. If the numbers are way off, the colleagues will correct me. So just the volume of ons, that people coming on every year to the waiting list is phenomenal. And there's enormous activity, and this year we hope to have combining the core HSE activity, both outpatients and procedures, additional activity the HSE will deliver, activity from the NTPF. We're hoping to have the highest level of activity, I think, ever within the system, and we hope to continue to make progress in relation to waiting lists. Definitely, Deputy, more bed capacity, will more staff and more bed capacity, but also reform. We can't have an investment without reform. We have to reform pathways, the way we work, in order to improve the flow and improve productivity. And small changes in productivity and small changes in how we work can actually deliver very significant changes. So we don't accept the fatalistic view in relation to waiting lists.
Do you think it's fatalistic? Do you think it's fatalistic?
I think it's fatalistic, yes. And it's not something that we can accept, that we're going to have a situation where people in 10 years' time that we won't. We're already seeing progress, so it's not fair to say, look, I'm not going to get into criticising the IHCA, they can look after themselves, but we have a plan this year to see improvements, and we are ambitious again for further years based on the commitment of resource we've gotten from the government, very significant investment, and it's our job now to deliver on that. In relation to inequalities, the most significant, in my view, unforgivable inequality is the fact that in the public system, people who have insurance status can access care in our public system ahead of people who are not insured. That's unacceptable, and the government accept that. And this inequality has existed for a long time. And with the new consultant contract now, we've made it very clear that new consultants who are appointed, and that includes new consultants in the system, and anybody who wants to move over to the contract, that they won't be in a position anymore to treat private patients in public hospitals. They'll have to deliver their public hours, and they can treat private patients outside. And it's not that we're any ideological objection to private medicine or private insurance or any of that. But when it comes to the public system, we believe everybody should be treated the same. And that is the biggest inequality, Deputy. Okay. And over time, we hope to address that so that everybody is treated on the same basis. Right. And that's good.
That's good. And I know it's kind of hard to predict, but obviously there's over half of the population rely on private health insurance.
Yeah.
And do you see a knock-on effect over the next number of years in relation to obviously outpatient, charges being dropped, and that's a good thing.
Yeah.
But obviously the implementation of Sláintecare, do you see a knock-on effect in relation to private health insurance, those that have to rely on it? And I understand why people do have to rely on it.
Sure. So I think it will have implications for the insurance market, the type of products that are made available by the insurers, and also by how that care is provided, how insured people are. I think that will take a long time, definitely, because we have a system in place for many, many decades. Changing that, we need to manage that carefully. We need to understand the implications. But it will have significant implications. Whether it changes the number of people who take out insurance, that will be a function, obviously, of people's own circumstances, their risk aversion, their financial capacity, and the ability of the public system to meet people's needs.
Surely, obviously, the next number of years when Sláintecare kind of, I suppose, is like rolled out, and obviously the perception in relation to universal healthcare and accessibility, surely then people will less be reliant on private health insurance. Surely that's the idea, I presume.
That will be one of the implications. If we had the public system that we want to deliver, a universal, affordable public system, well, then you would imagine that there'd be less reliance on private insurance. But that's ultimately a function, definitely, for individuals, the families, to make their own decision about that. And it's also, I think there's a big disconnect between the reality of the health system and the perception of the health system. In terms of what
I do agree with you.
So people are reading stories every day which frighten people, and probably unnecessarily, about access, and that, I think, does push people into taking out insurance.
That's a reality. I know. The vast majority of people that have accessibility to the Irish health system is a brilliant system, a really good system when you get into it. The problem is getting into it. And when you have situations like the Irish Nurses Midwives organisation have said, where 600 people are on trolleys, that's absolutely unacceptable, right? Sure. And you have, people waiting an inordinate amount of time to get some, a basic kind of surgical intervention. That's unacceptable.
Absolutely.
So if we didn't have this, is not somebody's mind,
Yeah, but there's structural problems there, definitely, including the fact that there are private patients in our hospitals who may be being treated for elective reasons in our hospitals in a bed when there are people in trolleys down in the A&E.
Yeah. So
that might be an issue too.
Yeah.
But again, so the whole system has to be considered. You can't just look at things in isolation.
No. And I think it's important. I mean, the Irish Nurses Midwives organisation is an organisation that's, on the front line.
Sure.
And they state on a weekly basis that there's hundreds of people on trolleys.
Yeah.
There's thousands of people waiting for a bed. That's, as I said, that's not something, that's the reality of the situation.
Absolutely.
Once you go beyond that, I think once you can fix that,
you
will have a system, where we can all say, look, this is universal healthcare. This is a system where, there's equality rather than inequality. And it's built in, as I said, this is a historical situation. Just my final point is on, just want to get the opinion of Mr. Gloucester's analysis of his tenure. And I know you said last week that you want to be hands-on. Well, what would be the kind of, I suppose, the judgment of your 5 years in your position over, and obviously if you stayed 5 years?
Well, I certainly hope I do, and as I said to you last week, I haven't my sights set anywhere else, and I did say to you last week, you should have been on the interview board with questions like that, but the Secretary General adequately represented you. So look, I did say to you last week in pretty straightforward terms, and you have to quantify it back up and all the big numbers, but I think we've just got to back down to the basics of any individual patient or member of the public you're talking about. If the critical things you're talking about, like access and like urgent care, if the experience of people in those isn't improving, then I won't have done a good job. And it's as simple as that. And that doesn't mean I can fix it all tomorrow, and I don't think anybody expects that. But the point about access, I made the point to you last week. When lots and lots of people are being referred for specialist services, that's a very good thing. Their health is being attended to. There's lots of new clinical technologies and clinical innovations. The issue for me is the length of time they're waiting. It's not the amount of people. Like we talk every week about the 800,000 people on the waiting list. That actually doesn't mean anything. What really means something is the length of time they're on it. And so shortening that time this year, albeit it's a 10% global figure, which some might say isn't ambitious. I think it is. Shortening that time and shortening the time and the amount of people that are waiting in emergency departments. Ultimately, if those experiences aren't better, because lots of other experiences are good, like you've said.
Yeah.
You get in, the quality is good. You go to enhanced community care, the quality of the intervention is very good. People's life expectancies increase, lifestyles are better, chronic disease, death from chronic disease is reducing. But the reality is, if people's experience isn't improving, then I haven't done a good job.
Thank you. Thank you.